Good morning, everybody. Thanks for coming. We have Dr. Sean Edmunds talking to us today about women's health and reproductive questions. He does not use a PowerPoint. He prefers one-on-one in these presentations. So I'm going to hand the screen over to Dr. Edmunds and we will get started. Thank you.
Thanks for having me. I know you guys have, let me get my video going here. You guys have been waiting to hear. We've had to reschedule this a couple times. A little background on me. I am a board certified OBGYN at St. Mark's Hospital. I am the department chair, so I'm the chair of the OBGYN department at the hospital and have been there for 6 years at St. Mark's now. I practice full spectrum, high risk and low risk obstetrics, but also am a minimally invasive surgeon, meaning any surgical procedures through laparoscopic approaches, things like that, to minimize recovery times, improve outcomes, minimize complications. So I spend about 60 to 70% of my time in OB, and then the rest in gynecology and surgeries, and do a lot of minimally invasive surgery, which has basically allowed us to take the historical, take 6 to 8 weeks off to have a hysterectomy and spend several days in the hospital, and has allowed us to people go home the same day and are 90% better within a couple weeks. So exciting stuff that we can do. But today, I know I've talked to you guys before in the past. I'm not sure who's been on these before. I'm gonna try to pull this up, that if there are chat questions, let me know. Speak up, because I'm not always going to see the little blip there. But I've been asked to talk about a few topics and then leave it open to Q&A. Historically, of course, we were able to do these in person, which was much more preferable to me, and which is why I historically don't use the PowerPoint, because I like interacting in person, answering questions and drawing things up. But we're going to make the most of COVID and still do this, and I hope to come back and visit with you guys again in person someday. So a couple of topics I felt like I have to address is COVID related to pregnancy and reproductive health. And then I wanted to talk about one of the most common things we're seeing with gynecology, and that's bleeding, and talk about what those common causes are and what we can do about them. And then another very common not just surgical, common gynecologic issue we would deal with is incontinence. And so I was going to talk about those things and then just get on my soapbox about general health at the end, and then hopefully leave time for questions. And if there are any specific questions, please don't be afraid to speak up. I can't see any of you, so I'm just alone in a room talking to myself here. I hope you're listening, but if you have questions, speak up. And long term too, if there are personal questions on here, or you have issues raised through this that you'd like to be seen, I am accepting new patients at St. Mark's as well. We always are. It's Sean Edmunds, and we've got St. Mark's OBGYN. We've got a website you can link through. On the website, you can even schedule appointments virtually, but through the website to come see us, although we have some telemed capacity as well. But if you have something more urgent and online, the availability is months out, sometimes call and talk to my nurse. You can always just say you spoke with me or participated with me in a lecture and had some follow-up, and they can always find a time sooner. So I hope that's helpful. But okay, first off, COVID. COVID is obviously, we're all tired of it. And like I said, I'd rather be seeing you in person, but it is what it is right now, and we hope that we can continue to make some progress where we can eventually find a new norm where we can be together. But a couple of things, common questions that come up with COVID. First one would definitely have to be around pregnancy. There's a lot of fear. I mean, with the goal of vaccination rates closer to 70%, we look at our pregnant women and the rates are closer to 30 to 40%, or had been. They are improving. but one of the big fears is, of course, vaccination in pregnancy. So the reason I bring this up is it's safe. I just want to get that out there, that it is safe to get this vaccination in pregnancy. And actually, as far as like, it's got a really cool backstory. There's a lot of fear about the vaccination, and we're not going to get into the politics of that, which unfortunately, my personal opinion is there shouldn't be politics about vaccination, but people have the right to their opinions, and it's become political. Um, the cool backstory of this is I don't know if any of you have taken the time to research where these mRNA vaccines originally came from, but my own wife looked into this. And had researched it. It's really actually cool story, and I won't go into details of it, but basically, discovery of mRNA vaccination is this amazing life work of a female scientist who she spent her life, and I think she'll probably get a Nobel Prize for this at some point, dedicating her life to how to understand the mRNA, like how to design an mRNA vaccine. For two main reasons. One was safety, because of the way it works, it's so safe. But two, a way to produce a vaccine quickly in the time of epidemics or pandemics. So it's actually a really cool backstory. Long story short, it's been around long enough now that it is safe. It used to be, I would tell my pregnant patients, because I always try to give full disclosure on this, that yes, the vaccination is safe. But there was a little subtitle that said, we don't have evidence that it's not safe for pregnant women, so we're going to presume that it's safe. But that actually changed a few months ago. They now have enough data about this to say vaccination in pregnancy is safe, with the subtitle now being, we have enough physical evidence to validate that this is safe for women trying to become pregnant or women who are pregnant. And the reason this is important is COVID has caused more problems for pregnant women than non-pregnant women. So the idea of being vaccinated, and vaccination does not eliminate your potential for getting COVID, but we do have good evidence that you're less likely to get it. And if you were to get COVID, that you are less likely to get severely ill from COVID. You're more likely to have a mild response because you have immunity built up. And we bring this up because there's three major things with COVID. One, we know that pregnant women who get COVID do have increased risk for illness and severe illness and hospitalization. We've unfortunately seen this firsthand at the hospitals throughout the valley. I have colleagues at Intermountain Medical Center, at the University of Utah, and obviously I'm at St. Mark's, but we've all experienced women in the ICU with COVID, and not high-risk women, 25-year-old healthy women, things like that. So we know that the risks of COVID while pregnant are higher. So one reason to prevent. Secondarily, we now have enough data collected. This has been around long enough that we can show that there is an increased risk of preterm labor when you've been infected with COVID. And preterm labor meaning delivering your baby before 37 weeks, when typical due date is 40 weeks. And then finally, we unfortunately do have evidence that there's increased rate of stillbirth. We saw this as doctors early, some unexplained stillbirths, miscarriages, things like that. But we now have enough evidence nationwide to say that it does increase the risk for stillbirth. So if friends were to ask you like, oh, I'm pregnant, I'm not sure, it's really simplified to, hey, we have enough evidence to call the vaccine safe for pregnant women, and enough evidence to say that if you get COVID during pregnancy, there are high risks, so just get vaccinated. So that's the, sorry, go ahead, somebody.
And that's okay, Dr. Edmunds. I'm not sure if you can see the questions, but this one I thought was important.
I won't, because,
Okay.
let's see, let me see
The
if I
question
can.
is, I was told that the vaccine also helps to protect the placenta when you are pregnant.
So that is probably an extrapolation of data. And I'll tell you the short answer on that. Let me see if I can pull up, I'll try to pull up those questions in the corner so I can see. I apologize. One of the reasons we think there is an increased risk of stillbirth, miscarriage, and complication in pregnancy is because of the way COVID affects our clotting factors. So it's been known since early on that people who are severely sick with COVID and to the point of hospitalization, for example, had higher risk of blood clot, DVTs, pulmonary embolus, things like that. So initially, there was actually some argument toward, hey, any pregnant woman who gets COVID, should we put them on a blood thinner for a couple of weeks? And that data hasn't been strong enough to really argue for. There's even debate in the Valley. So, but the idea is that if there's increased clotting, that clotting at the placenta increases your risk of stillbirth, growth restriction, preterm delivery, all those things. So in effect, avoiding COVID is protective against issues with your placenta. So it's not that the vaccine itself protects the placenta, it's that the vaccine prevents you from getting COVID, therefore protecting your placenta. Does that make sense?
Yes, it does. Thank
Hope
you.
that covers it. So yeah, it's more of an indirect effect. The other thing, so any other questions about COVID and pregnancy? I was going to talk about some common topics with like general menstrual health and things like that. And I can't see the questions. I try to pull it up and I don't see them,
Yeah,
so I
I'll let you know
apologize.
when there's a question. I have a
Thanks,
question.
Kim.
Do you see that pregnant women do not do other vaccines when they're pregnant, or just the COVID one?
So no, I think most vaccination follows the same. It's just like in general, most people are vaccinated, but there's been hesitation about COVID vaccination, largely due to misinformation. And so that's true both pregnant women and non-pregnant men and women. So it's just been heavier in pregnancy because, we are trained and conditioned to think you can't do anything when you're pregnant. You can't take anything. You can't do all these kind of things. Um, and so that's led to less pregnant women getting it. But initially, the reality is it wasn't until September that the safety recommendations switched to we have evidence of safety. So numbers are going up for vaccination.
Right.
I
So
think
the next
there's
question is, any information on the vaccine or COVID illness during breastfeeding? Does it protect the baby?
so similar. So when you get vaccinated, cool thing during pregnancy, the vaccine doesn't cross placenta, but the antibodies you make do. The antibodies you make will cross the placenta, and so baby's born with those. The baby's immune system, really, for about the first 3 to 6 months of life, is just the mother's immune system shared to the baby. So if you look at like number of antibodies, immune response in the first 6 months of a baby's life. When baby's born, they're born with mom's antibodies, and over the course of 6 months, they wane off. But over that 6 months, they start to build up their own. So when you're pregnant and get it, baby's likely born with some antibody protection, but also, and there's different types of antibodies to keep it simple, but with breastfeeding, you do share antibodies to your baby too. It's a different type of antibody called IgA. It's similar to the kind of antibodies that line our gut and things like that. But that is shared in the breast milk, and there's some protective factors that are shared in the breast milk. So it is safe to vaccinate while breastfeeding as well. So prior to pregnancy, during breastfeeding, it's all been proven to be safe. And there's likely some antibody shared through the breast milk of someone getting vaccinated. Any other questions with that? So in effect, your immune system protects baby for the first few months for anything you share during pregnancy. And then if you are able to breastfeed, there is some immune protection shared to the baby. In short answer, I could have just said that. The other question I wanted to bring up is we get a lot of questions about, well, there's these reports, I got the vaccine and then my period was irregular or something like that. This has been looked at extensively because of sometimes on a regular cycle, or the most common thing I heard is I got the vaccine, my period was a little different the next month, and then it went back to normal. The key being went back to normal. And I think the short answer on that is we know that stressors can disrupt the cycle. And getting an illness, getting a vaccine, things like that can disrupt temporarily. The unfortunate thing is that's led to then false information about it affecting fertility and long-term cycles and things like that. And that is not proven to be true. They are tracking this. They're collecting data. They're collecting reports. It's harder to track how a one-time, like a vaccine, will affect someone's cycle months later because there's so many things that go into the cycle. But based off of all the information we have, my opinion on that is yes, there are some women that might have a disruption in their cycle, like the following month or a change in their period, but it's hard to really tell how much of that might have been a normal fluctuation versus related to the vaccine. But in experience with my patients, the second, the third, the fourth, and fifth month all tend to go on to be regular. So if there is any effect, it's very transient and short-lived, and there is no evidence that it affects fertility. Frankly, there's not been any drop in pregnancy, conception, deliveries, so we have good evidence to say that that's safe. Okay,
What about
so
mammograms? You know, there's a lot of women are told they should wait at least 3 weeks to get their mammogram after they've had a COVID shot.
So the only reason that, so this is opinion, and the only reason it would exist is after vaccination. You know, it's usually a shot in your arm, right? So in COVID, it's a shot in your arm. Your body is going to have an immune response that could affect the closest lymph nodes, like so in your armpit, axilla. And so in breast exam and mammogram, if they saw a node or something like that, it could lead to a false positive. The likelihood of that is pretty low, actually. But that would be the reason for that. Now, I think personally, if someone, hey, I got my mammogram scheduled months ago, and now I'm realizing, oh, it's 2.5 weeks after my COVID shot, I would still just get the mammogram. But if you can help it, that's why they'd say to avoid. Now I can see the questions now. I pulled it up. I got a couple questions. How early can the sex of baby be determined? On blood work, you can determine as soon as 9 weeks. On ultrasound, as soon as 14. Can you work out? Yes, 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 and please do. Um, uh, Long story short, we used to treat pregnant women like they couldn't do anything, like you were fragile, like you were incapable, and that's just been wrong. For the same reason, working out, with all the examples given on this question, is good for you as a woman. It is also good for you as a pregnant woman. So what I would recommend, and I tell all my patients, yeah, exercise, stay active, do the things you like, because if you can eat healthy, stay active in your exercise and things like that, then it's going to make a difference. And I can promise pregnancy, delivery, recovery, everything goes better when you stay active. Should women start taking prenatal vitamin if they're trying to get pregnant, or wait until they have a positive test? Start now. There's good evidence that if you take the prenatal vitamin for at least 3 months before the pregnancy, you'll have better preloaded yourself with folic acid and necessary vitamins and minerals. But also, one study even showed that women who took their prenatal vitamin in advance tended to have less nausea, which is a huge thing for those of you who have been pregnant or seen someone been pregnant. That nausea is a huge limiting factor of that first trimester for many women. Okay, I'm going to jump ahead to these other topics I talked about, and then we'll leave more time for Q&A. But of course, like I said, feel free to interrupt me at any time too. So the two most common gynecologic complaints I see are bleeding. Sorry, I said the most common is bleeding, and then the second one that I often have to ask for is incontinence, and this is a common issue, especially after having children. So I wanted to break it down to say, like, okay, when you come to my office and you're saying I'm having irregular bleeding, what are we thinking of and what we're doing? Because we're going to get a history from you, and we're going to do an exam, and we're often going to send you for an ultrasound. The reason being is because bleeding can really be dropped into like 8 general categories. 4 are mechanical and 4 are more medical. So mechanically, there's things that can be going on, like a polyp, which is a benign growth in the uterine lining, adenomyosis, which I'm going to jump back to in a second, fibroids, which are benign tumors in the muscle wall that can push in the cavity, push out, and malignancy. So when we look at this, we think polyp, higher risk in someone who's a high estrogen effect, which is unfortunately more common with obesity. Our fat cells convert testosterones into estrogen. You end up with excessive estrogen. It can cause polypoid tissue. And then polyps are less stable than the rest of the lining, so tend to bleed. Adenomyosis. A lot of people have heard of endometriosis, which is a whole nother discussion, but it's basically where your uterine lining is growing outside the uterine cavity. And so it's commonly known about due to pain, very painful cycles, pain with intercourse, things like that. Adenomyosis is where you have your uterine lining growing on the muscle wall of the uterus, but it grows into the muscle wall of the uterus, leading for it to grow and shed within the muscle wall, and it's often associated with pain or bleeding issues. Um, Leiomyoma, or fibroid, as it's commonly known, is a benign tumor in that muscle wall as well. And then malignancy, of course, we have to worry about. So structurally, we're thinking of those things, and those can be determined by exam, ultrasound, and sometimes we have to do an endometrial biopsy where we pass a little straw into the uterine cavity and suction back, and it can collect some tissue. Apologize, my partner's just calling. Sorry, can you guys still hear me? My AirPods tried to connect to the phone, I think.
Yes, we can hear you.
Okay, thanks. And structural things tend to lead to structural responses, meaning more likely to need surgical answers, removal of the polyp, removal of fibroid, or if someone's done with fertility and done having children, consideration of hysterectomy depending on size. The second thing we think of is medical, and that's coagulopathy, meaning like a bleeding disorder. So it's usually something that the bleeding has been an issue since the beginning, and there's oftentimes family history or things we can test for. Ovulatory disorders, idiopathic, meaning like we've caused it somehow with herbs, supplements, medications, interventions. Or the fourth category is kind of a cop out, but it's not otherwise specified. And that's the medical way for us to say, hey, we ruled out all the other things. You might just have a dysfunctional lining. And for those, we're more likely to have medical options as well as surgical options. Medical options meaning hormonal options to control, which oftentimes are birth control, or in other ways handle those things. So the honestly, of all of those things, if a woman's younger than 30, the most likely one is the ovulatory one. If you're over 30, those structural ones start to come into play. And specifically the malignancy, when we worry about uterine cancer, that is most common in 40s and 50s and later. But the number one way to avoid it is healthy life. Unfortunately, just like I told you before, our fat cells convert testosterone into estrogen. That estrogen can lead to a built-up of the endometrial lining. And what happens if chronically over time, if that lining is always being stimulated, and growing, not only can it lead to some irregular bleeding because of instability of the lining, but hyperstimulation of it leads to something called hyperplasia, which overgrowth leads to more likely mutation and uterine cancer, which is why 80% of endometrial cancers, which is that uterine lining cancer, are actually related to obesity. So taking care of yourself, maintaining healthy diet are critical, which is why we don't like irregular periods too, because we think, unfortunately, with that ovulatory cause for irregular bleeding is you're not ovulating, and oftentimes that is related to obesity, but it can be related to other things like PCOS, or other, there's a variety of things that can make you not be ovulating. But what happens with that is normally you should be, your cycle is really a cycle going up and down, right? So when your hormones peak and your estrogen peaks, you've built up a nice healthy lining. Your progesterone peaks and you ovulate. But if you don't get a signal of pregnancy within 14 days, those hormones drop. And that big swing down leads to the shedding of the lining in the period. So if someone's not having a regular period, or they're really irregular, the first assumption is you are not ovulating. And short term, it leads to the annoyance of heavy and irregular bleeding. But long term does put you at high risk for that that uterine cancer, because basically what's happening is we think if you're not ovulating, meaning you're not cycling and having the drop and shedding your lining is going to build up more and more and more. All right, so I've got a question here. Most women do not know they are pregnant until their missed period. Is it harmful to the baby to have alcohol before the missed period? So that is a great question and a super common one. in an ideal world, you don't drink alcohol when you're pregnant. There's arguments toward very small amounts being okay, things like that, but we know that larger amounts are dangerous. So for most people, try to avoid alcohol in general. Um, it is very common when you think about it. 50% of pregnancies are unplanned. So let's assume 50% of pregnancies are at risk for maybe a drink because they didn't realize they were pregnant yet. But the reality is, even some of the planned ones, maybe someone had a drink at a party because they didn't assume they were. In moderation, it's not probably concerning at all. If someone misses a cycle and has had alcohol, our recommendation is to stop. Now, if someone's been drinking heavily, of course, there's always higher risk. So there's heavy alcohol use. That's an issue. But otherwise, it's a common thing, and we just recommend stop drinking once you get pregnant or once you have that confirmation. Okay, so any questions about irregular bleeding? And long story short, what I'll say about when we think about these 8 categories, if you're having an irregular cycle, that's never considered normal. And there are ways to correct it, whether it's diet, exercise, lifestyle changes, medications, even surgeries sometimes. There are ways to correct it. So we would recommend you be evaluated. Any questions about that? All right, I think we're good. Okay, so the last thing, and the reason I bring this up is incontinence. It makes an OBGYN sad to walk into a pharmacy or a store and see this huge aisle dedicated to pads and ways to basically hide the fact that you're leaking urine. Pads to wear, liners to wear, things like that, because incontinence is a treatable condition. So much the way it makes a lot of doctors sad to see so many people sick in the hospital with COVID when we know we can vaccinate against it and prevent that. It makes an OBGYN sad to see incontinence issues being treated just by saying, hey, wear a pad. And so I'm not going to talk about all the root causes for incontinence. I'm only going to talk about the 2 most common, and that's stress incontinence or urge incontinence. So when someone comes to my office and says they're leaking, the first thing I'm trying to figure out is what kind. Now, there are a variety of different kinds, neurogenic, trauma, like these other things, but the most common 2 are stress and urge. So I'll talk about those. Stress incontinence is the incontinence we talk about when there is you cough, laugh, sneeze, work out, jump on the trampoline, and it just comes out under pressure. So it's that stress leads to the leak. Urge incontinence is actually a bladder spasm. This is the commercials you see on TV that are saying, oh, do you have that urge to go? And basically it's this urge like, oh, I feel like I need to go. And if you're not getting to the bathroom within a minute, your body goes. And that is because the detrusor muscle in the bladder is squeezing. So those commercials you've seen for Detrol or these other medications where there was a really popular one where the stick figure woman from the bathroom symbol is like kind of squeezing her legs together and running off to the bathroom. And that's urge incontinence. So briefly with urge incontinence, there are things you can do, but it is related to hyperstimulation of that detrusor muscle. There are medications you can take to relax that. Some have side effects, and so you're kind of working through side effect profiles to see like, okay, let's get the maximum benefit and avoid the risks. But also, it's more common when the bladder is full. So simple things you can do at home if you're not ready to go be seen about this is make sure you're doing timed regular voids, meaning every couple hours you are going to the bathroom, because an overfull bladder is more likely to have the urge stressor and lead to that emptying that happens with the squeeze of that detrusor muscle. Now, stress incontinence has multiple fixes. Basically, what it boils down to is this. The most common cause of this stress incontinence is childbirth, because through childbirth, the vagina, which is smaller caliber than a baby's head, obviously has to stretch to fit a baby's head and body through. And so there can be stress on the pelvic floor. So when there's that stress on the pelvic floor, there's weakening around the urethra, so there's not good support, so you leak. Basically, the idea is, if anyone's watching on video, my fist is the bladder, my finger is the urethra, and my other hand here is your pelvic floor. So normally your pelvic floor is sitting right there, so that when you cough, laugh, or sneeze, or there's pressure down on the bladder, there's a support there that can kind of catch it. because there is a sphincter around the urethra too, and that's what we relax to go. But when we cough, laugh, or sneeze, there's that support there, so we don't just leak. The idea is that that support is weakened. So with stress incontinence, the most common causes is childbirth, but also can be related to just poor pelvic floor support, which means poor strength and muscle tone. Can get worse with age, can get worse with obesity, which leads to a common conundrum of like, okay, I have some incontinence. If you can lose some weight, it might improve, but it's hard to exercise when you're leaking all the time. So women run into this issue. Long story short, there are multiple ways to fix this. And so the reason I mention this is like, yeah, I don't want any of you someday walking the aisle picking out pads because you leak all the time. Come see us, come see me, and let me help you. But we're looking at basically ways to support that pelvic floor, okay? So first off is Kegels. Second, there's a ring you can be fitted for called a pessary to fix it. And third, there's surgery. And so I'm going to go into the details of those. Kegel exercises. Most people have heard the term. Most people have tried them, but it can be a little confusing. The idea is you're trying to flex your pelvic floor and strengthen it. And it's not like working your bicep where you're pulling, 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 and just trying to get repetitions. It's more tone in general. So we talk about squeeze and hold. The best way to test this is either you can place a finger in the vagina and try to squeeze the finger. That teaches you how to use Kegels. Or it's the same muscles we use when we're trying to stop voiding. If someone is leaking, if we're going to the bathroom and you want you to suddenly stop, your kid runs in on you and you're like, oh crap. I don't recommend practicing it that way because then you're practicing trying to stop voiding when you're trying to go all the time. And but if you need that to initially get the idea of like, okay, how do I do it? But what we recommend to people is several times a day, spend a few minutes. Now, the cool thing about Kegels is, yes, it's a little weird to figure out at first, but once you know how to do it, you can do it at your desk, you can do it in the car, in the bus, at lunch. Nobody has to know you're working out your doing your Kegel exercises when you're doing your pelvic floor. But we recommend that. Now, if that's not enough, that doesn't mean, oh, I tried it at home, it failed. There are a lot of awesome resources now. First, we have amazing physical therapists, many locations right here in our valley with women who are physical therapists who have trained to go above and beyond for women's health. And so these physical therapists work with the diastasis, the muscle separation in your abs, pelvic pain, prolapse, incontinence, because stress, incontinence, and prolapse often go together. But they can work with you, and although that may seem a little embarrassing at first, the idea is that they will kind of assess your muscle tone and work with you and give you exercises, so it gives you an even better chance. It's just like working out on your own versus working with the trainer. This is like the physical therapist is the trainer that can help. So there are really good resources. And if that seems a little nerve-wracking to go and have someone help you through it, there are a lot of cool tools online now and companies that are coming out with devices you can basically insert in the vagina that teach you how to do your Kegels, even play games on your phone that tell you when to squeeze, when to relax, when to squeeze, and it makes it more interactive and more successful. So there are a bunch of really cool resources on how to strengthen your pelvic floor, which will help with prolapse, help with leaking, incontinence, and things like that. And even if there is incontinence of gas or stool, which rarely but can happen with childbirth too, strengthening that pelvic floor. So using those resources are really cool. That second option is a pessary. It's a little rubber ring that you can get fitted in to basically hold pressure against the urethra. I'll be honest, I don't do a lot of this, and we do so little, I refer it to one of my partners. And the main reason is just in my experience, people don't like it. If Kegels aren't working and you're wanting to avoid the next thing, surgery, it's an option. But most active women don't love fitting this ring in and out and trying to get fitted. But it is an option basically to mechanically hold pressure there. The third option is surgery. Sometimes you do everything right. You buy the devices, you see the therapist, you do your Kegels, but you're still having some leaking. And the reality is it could just be that that tissue was damaged too much. So we can do surgeries to correct it. The most common and most effective one is called a sling. It uses mesh, which is like this buzzword because there were commercials on TV about lawsuits against mesh. I want to clarify that mesh was mesh that was used to fix prolapse, meaning if women's vaginas were pushing out, it was this mesh used to tag it and pull everything back up. it was bad news. It is bad news. It's off the market. There are justifiable lawsuits trying to help women who have had extreme loss of lifestyle, sexual function, chronic pain because of them. That is not what I'm talking about. The mesh we're talking about is this tiny little strip. And the idea is that if the weakening is right here, if we can structurally support that again, like I said, with Kegel exercises is our first goal, but if we can get a support there in another way, when you pee, it's going to catch and not leak. So the problem with that mesh that was really used for prolapse, it was cinched up, it was pulled tight, and then mesh always naturally retracts a little bit, so it caused more tension and then complications. This mesh, we're literally just creating a shelf. So when I do this, basically you're under anesthesia and we do a surgery, and I place this mesh kind of like right like this, like in a U shape, not tugged against your urethra, not kinking your urethra, but just sitting there. So then when it does heal in place and tightens a little bit, it's still not causing any problems, because we need people to still be able to relax and pee, but also that when you cough, laugh, or sneeze, that's going to catch. So it's called a TBT sling. There's a variety of different ways to do it, but basically, if nothing else works, we can surgically correct it with a sling. So, um, those were my three topics I really wanted to hit. COVID, because I feel like there's always questions, and misinformation has caused a lot of questions. So I hope good information is it's safe and all that. The common causes of bleeding, and most important, if you're having irregular bleeding, don't hesitate to be seen. And teach your friends and family, same thing. Hey, irregular bleeding doesn't have to be tolerated. And there can actually be risks with certain irregular bleeding, like higher risk for uterine cancer later in life, or even currently if you are older. So be seen and be evaluated. And then finally, incontinence does not have to be tolerated either. There are fixes for the two most common causes, which is really going to catch 98% of women or more with those two causes. So there are fixes, there's corrections, there's ways to be proactive. And so don't do such a good job at taking care of everybody else that you forget to take care of yourself. And so those are important things to come in. And so finally, my soapbox, and then I'll open any questions before letting you guys get back to life. With everything I talk about in medicine, we have fixes, we have corrections. We look at medication, surgeries, all these things, but a lot of if we really want to avoid those things, which most of us do, right? Who wants surgery? Who wants medication? The best way to treat all this is we need to take care of ourselves. And it comes down to like a few base categories is how are we fueling our body, meaning how are we eat? And I hesitate to use the word diet because it's been convoluted into what a diet is, but I'm saying diet and what you eat. There's all these plans about how to lose fast and things like that. But the reality is you got to think the best way to think about diet is how am I fueling my body? Am I fueling my body in a healthy way? Sleep. You have to sleep. If you want to be healthy and lower stress levels and keep a healthy weight or lose weight, you have to sleep. And we're kept up by our screens constantly. I'm getting called, I'm getting texted all through this. We have access to all these things that keep us up, up, up. And I'm guilty too, but we have to get sleep. We have to stay active and exercise. The recommendation is that we get 30 minutes of cardiovascular activity most days of the week, whether you get on a walk, a run, a jog, a bike, a swim, yoga, get your heart rate up most days. And take the stairs, take the longer walk, do these things, but also resistance. If we can use our muscles, it puts stress on the bone that keeps our bone healthy. Because if you don't stress your bone, basically, military figured this out years ago. They have, or fighters figured this out. If you can strengthen your bone, you're less likely to break. So they'll go through these stress exercises to stress their bone to make it stronger. When we use our muscles, we're putting stress on our bone and making them stronger too. And that's the great way for women and men. But it's a big issue with women in menopause is osteoporosis, bone weakening leading to bone fractures, hip fractures, things like that can really take you out of the game health-wise. So that should be 2 to 3 days a week you're getting resistance. If you're not a gym goer, if you don't have things, you start with body weight resistance. Literally Google. We have amazing resources. I knocked the phone a little bit here, but we have amazing resources on home activities that you can do, and just say home resistance exercises, whether that's getting bands or using your own body weight. Start doing those things. And all of these help lead to my fourth category, which is stress. We got to find ways to reduce stress in our life. We are a high stress society. The last 2 years has not helped. It's made things worse. We're stressed out. We're not taking care of each other or ourselves. And so I just want to say, fuel your body, get sleep, be active, and find ways to reduce your stress. And that's unique to you, but we gotta find those ways. And if you do those things, a lot of these other health things are better off or preventable. Okay, so that was my soapbox, and I got another question. Okay. Can you talk some about perimenopause? What's normal, what's not, and how do I know the difference between perimenopause and a problem? That is a great question. So, perimenopause is referring to those years leading into menopause. Menopause, by definition, being at least 1 year without a period. Average age of menopause is 50 and a half years old, but most women go through menopause between 45 and 55. And perimenopause is those years that transition. Some women, it's a short time over a year. Some women, it's several years or longer. But perimenopause is basically that time. And you got to think of it this way, because I think what you're getting at is like, how do you tell a difference between irregular bleeding of perimenopause versus a regular bleeding that's a problem? And it's based off of severity. Just like women start their period, when you start your period, it's not always regular and it's not always ovulatory. It actually can take 6 months to 2 years before periods start being ovulatory for women as they start their period. Now, on the tail end, as it's going away, that same thing can be true. I mean, you're not ovulating nearly as much, obviously, in your 40s, and that falls off, and then periods can start to become irregular. So know that in perimenopause, some irregularity of your cycle can be normal. So 45 to 55, some irregularity can be normal. The difference is if that period's getting more painful or heavier or altering your life in negative ways, then you should be seen. So when I go back to my my polyps, adenomyosis, the fibroids, these things like that, they're almost always associated with bleeding that gets heavier or more frequent. Irregular bleeding related to perimenopause usually means it's trying to space out bigger gaps and a little more irregular. But if you're like, no, I'm getting a period every 2 weeks or more frequent, heavier, more painful, that's when you should be evaluated and see someone about it. And then, unfortunately, once people are in menopause, that's when you start to get hot flashes, vaginal dryness, moodiness, things like that. And that's where we start to then try to replace hormones to treat symptoms or talk about lifestyle changes. And that would be a whole nother hour discussion. But if you're getting to that stage and having the hot flashes, having the irritability with it, having vaginal dryness, which is usually manifests as pain with intercourse, that's when you want to go see your OBGYN or your primary doctor, and or come see me if you don't have one, and we can help you through those symptoms. Any other questions?
Yeah, here's a question. What are specific problems when a mom is under stress or has untreated mental illness while pregnant?
What are specific problems when a mom is under stress? So under stress is hard because stress, we're all in stress, and so babies are really resilient to that. But I think the bigger thing there is untreated mental health. Um, Once again, the problem with pregnancy is women are often told they can't take anything. So sometimes women stop mental health medications, and it's not black and white like that. It's not like with depression or anxiety, you can say, well, I don't want to take that antidepressant or anxiety medicine during pregnancy because I'm going to suffer so that it's for the benefit of my baby. We actually know that untreated anxiety and depression, for example, if severe especially, can lead to higher risk for pregnancy, higher risk for preterm birth, preterm labor, higher NICU admissions for baby related to those. So the reality is, if someone is experiencing anxiety, depression, other mental stresses, they should be talking about it with their OBGYN. So if they're pregnant, I'm hoping they have an OBGYN or a midwife that they're seeing. You should be bringing those things up. And frankly, if you feel like you're not being heard, it is okay, because I'm not a perfect person, right? Like, I try to listen to people when people bring those red flags, but maybe sometimes we miss them, right? So if my patient, and I tell my patients this, if they feel like I didn't hear them, they tried to express a concern and I forgot to address it or I brushed past it, I invite them always, stop me if I'm not listening to you, because I want my patients to be heard. But if you're trying to do that and you just feel like you're being blown off, even when you try to address it, then sometimes you got to find a different doctor or a midwife, because you can't ignore those things. Mental health is huge. It's becoming more and more in the forefront of how we care for people. I don't know why we separate mental from physical health so much, because the reality is, it used to be someone had physical complaints and then you'd get told it's all in your head, and that was like my big negative. My doctor won't believe me. They say it's in my head. But the reality is, physical and mental are, I mean, mental, it's our brain. It's part of our physical body, and we can't ignore those things. So for years we've separated them. For years we've had stigma with mental health. I'm very optimistic that that's changing, slowly changing, but changing, and that we have to connect those two things. Mental health affects our physical health affects our mental health, and it's all one and the same. So if you are having issues, you got to bring it up, you got to talk about it, and sometimes you have to do treatments, whether that's therapy, or medication, or both. Hope that answers that. If there's any follow up on it, let me know.
It
I
does,
can
it
see
does.
some.
Kind of following that, what about baby blues and postpartum depression? And
Yeah,
what are doctors looking at now to help women so they don't get lost in that, so to speak?
yeah. So I think part of our cultural shift is helping with that. But the reality is this: 80% of women are expected to get baby blues. I think it's probably more. Baby blues are the nice, soft term to refer to the depression, anxiety, the symptoms that can happen in the first really 2 weeks after a baby's born. And the reality is that's a stressful time. It's a beautiful, amazing time, but it's a stressful time. There's lack of sleep. You're trying to figure out breastfeeding. You're trying to recover from birth. And so it can be really hard on women, and couples as well. But obviously, more of that weight is felt by the women, even in supportive couples, supportive partnerships. Baby blues is that term. And then postpartum depression or anxiety, which includes, we call it postpartum depression, but we're really talking about depression, anxiety, OCD, psychosis, all these things that can happen, with each of those things becoming less and less rare on that list. Or sorry, less and less common, more and more rare on that list. But we have to have active discussions. So I can't speak for everyone. I can tell you what I do. We talk about it in the hospital before they go home. We talk about, okay, that was beautiful, this is amazing. We work through any issues with breastfeeding and things like that. We make sure people have their resources for the physical things, because once again, if physical is not taken care of, it affects our mental. But also, we talk about the mental. You have to recognize going home from the hospital or going home from birth that your risk for blues, as we call it, is really high in the first couple of weeks, and that's okay. But the risk for postpartum depression, anxiety, and that's something that persists or is getting worse, is about 20%, which is really high too. If you think 1 in 5 women are dealing with it. So I talk to people and say, we're always saying, hey, if your bleeding gets worse, your pain gets worse, you get fevers, chills, these physical things to watch for. But I always include in that, if you're having worsening depression, anxiety, I've heard people I had one doctor, he used to tell his patients, if you find yourself just staring off at the wall and totally lost, remember this conversation and call us. Come get care. If you find yourself just like overwhelmed, you gotta address it. So, and I always include the partner of the patient with this too. Like, they watch for it. It's okay to say, I'm depressed, I'm anxious. And it's normal to not feel great all the time after having a baby, obviously. So it starts with making it normal to feel abnormal. It's follows up with making sure the partner of that person is aware too, that he or she can be supportive as well. And then it goes to like, okay, well, how do I get help? And that it's okay to call for help if I need to. So, and when I've been more proactive about that, I don't know if I always was as a brand new doctor, but as I'm more proactive about it, we get those phone calls. And sometimes it is a, hey, let's try this, or let's be aware. But sometimes it's a, let's get you in today and let's get you resources. So you just can't ignore it. You got to be on top of it. I tell my patients that the the only time we really see people get in big trouble, meaning trouble of hurting themselves or others or really spinning out of control, tends to be when we try to ignore it. You just can't ignore your health, whether that's mental or physical. Any other questions?
Yeah, I just want to ask, I just want you would, I'd appreciate if you would remind women how often they're supposed to have a pap smears and how often they're
Yeah.
supposed to have mammograms and start those.
Okay, so pap smears start at age 21, recommended every 3 years until you're 30. And if it's ever abnormal, they'll test for HPV, and then the kind of the algorithm changes. If it's ever abnormal, we go to more frequent screening, testing, follow up. Age 30 up to 65, we say every 3 years plus an HPV test, and there's even evidence to say you can go every 5 years plus as long as you get an HPV test saying it's negative. So as long as you have negative HPV, because human papillomavirus (HPV) causes cervical cancer. So if you've always been negative and everything's normal, you can go to every 3 to 5 years after age 30. Although most people stick with 3 out of a comfort zone. But we still recommend annual exams, meaning like come get an annual checkup, because we're not just, the pap smear is just to swab your cervix for cervical cancer risk. We still are listening to heart, lung, checking thyroid, talking about lifestyle, talking about diet, exercise, all these other things. So annual exams every year. Pap should be every third as long as normal. And if it's ever abnormal, it would be more frequent. Breast exams should be every 1 to 3 years, they suggest. And that's based off family history and personal preference on checking. So a lot of times my patients want me to just do an exam while I'm checking their heart, lungs, abdomen, all the other stuff. But every 1 to 3 up to age 40, and after age 40, an actual exam with a doctor should be yearly, and mammogram should be yearly at least by age 50, and some people argue yearly by age 40. The recommendation is between 40 and 50, you should start them, and depending on family history and personal risk tolerance, you start them either annually at 40 or some sort of in between, but definitely annual by age 50. The long story short with all this testing is that the more you test someone, the less likely you are to miss something, but also the more likely you are to get a false positive. So that's why we spaced out the pap smears to be less frequent, since it's a slow moving disease and we don't have to be every year like we used to be. Same thing with mammogram is doing it every year in your 40s might increase your risk for a false positive a little bit. But if you have a family history or a personal, you don't want to take that risk, then we kind of make that judgment call based on the person. So on the mammogram, it's a little bit choose your own adventure in your 40s, but talk that through and make an educated decision with your provider. But perhaps every 3 years, unless there's abnormality, it becomes more frequent.
Great, thank you. Another
Yeah,
question is, what about a digital exam? How often?
I need more detail. Uh, digital exam, like, because we check cervixes in pregnancy, in labor, a digital exam. Yeah, we do rectal exams if needed. We do. Yeah. So I guess I need more
Oh,
info on
she
what that
says
means.
to check for ovarian problems.
Oh yeah. So unfortunately, digital exam for ovarian is not great, but it's better than nothing. We don't have a good ovarian cancer screen. So oftentimes when we're doing exams, we do a pelvic because, and this is a little bit risk versus benefit kind of thing. Even if we're not doing a PAP, we'll often do a pelvic, meaning we look at your skins because it's a skin exam, but a digital exam to feel for ovarian masses. Unfortunately, a small lump is likely not going to be felt on a digital exam. But if someone has a higher risk for ovarian cancer, which can be seen with age or family history, a digital exam, the hope is it could palpate any mass or structural abnormality to then send someone for a follow-up ultrasound. So that would be a risk assessment to discuss with your individual provider based off of your history.
Great. Does anybody else have any questions? I'm not seeing any at the moment. Let's give everybody just a few more seconds to ask something.
While we do that, hey, it's been an honor. I hope we get to do this in person in the next year. It'd be more fun to interact in person. I can tell if I'm being funny or not because I can actually see your faces and react. If you have questions and need to be seen more, I'm more than happy to see you in the office. And St. Mark's is a great place. St. Mark's OBGYN is an awesome office. And it's been an honor. I hope some of this was helpful and at least gave you something to learn about over lunch. And Happy New Year to everybody and happy holidays.
Great, Dr. Edmunds. I'm not seeing any other questions, so I'm going to say happy
Okay.
holidays to you and happy New
Okay.
Year. And I do hope we can get back in person eventually. That would be very nice.
All right. Take care, everybody. We'll see you.
Right. And we're getting lots of thank yous. So just so you know.
You're welcome. Thanks for having me.
Uh-huh. Bye-bye.